Hello, everybody. Can I start?
Hi, everyone. Let me introduce you, Chingiz Nurimanov. Dear students, today before us will speak a vascular neurosurgeon of the second category in the National Center of Neurosurgery in the city of Nur Sultan. Chingiz Nurimanov, what to you?
Hello, everybody. My name is Nurimanov Chingiz, and I'm a neurosurgeon for vascular neurosurgery department in Nur Sultan. We are specialized brain arteriovenous malformation, arteriovenous aneurysms, carotid artery stenosis, and other functional disorders. I am going to talk about intracranial aneurysm and treatment strategies in our center. As you know, cerebral aneurysm, this is expanding on vessel wall, and prevalence is about between 0.4 and between 3.6% in autopsy studies. You're everybody students here? I'm sorry.
Yes, yes.
Aneurysm divided, classified many types, and in shape we can divide it 3 categories. First category, this is saccular aneurysm. Second category is fusiform, and third category is dissecting aneurysm. And we have a little bit another categories. This is blister-like aneurysm. This is a little bit aneurysm, and aneurysm don't have a neck. Location. Most commonly, aneurysm located in anterior circulation. As you know, circle of Willis, about 40% aneurysm located ACOM, anterior communicated aneurysm, and 30% located MCA bifurcation, and less than 10% located posterior circulation, precisely basilar artery trunk bifurcation. And size classification, we divided aneurysm 4 category. This is microaneurysm or small aneurysm. The size is less than 7 millimeter. Medium is about between 7 and 50. Large, more than 50 and less than 25 millimeters, and the giant is all aneurysm is more than 25 millimeter in diameter. And as you know, every aneurysm has a dome, body, and a neck. And especially we need to know about neck, and wide neck or narrow neck. Everybody knows treatment option of aneurysm. In whole world use 2 treatment option, and not everyone center use a combined microsurgical and the vascular option. The surgery microsurgical option, this is a clipping a neck of aneurysm, and the second option is endovascular option. We use endovascular technique and the special catheter, and use a coil. The main goal of use this endovascular option is cut off aneurysm in blood flow. I am gonna talk about the history of aneurysm surgery. Our foundation father of neurosurgery is Harvey Cushing. He's first tried to ligate ACA, internal carotid artery, but unfortunately, patient died 2 days after he ligated internal carotid artery, and this is a bad result. First direct operation on the in aneurysm was performed Norman Dot in 1933, but you are in Dandy Club and Walter then the first time put aneurysm in 1938. In 1968, Gazi Yashirgil performed first time in the world external carotid and internal carotid bypass surgery. After this, more technique is developed, and in 1990, Guido Guglielmi discovered us best endovascular option is he used detachable Guglielmi coils, and after this, endovascular era developed so faster. In 1911, second huge progress in endovascular surgery was done, and we used pipeline endovascular devices. These devices is flow diversion. What about flow diverter? As you know, this is a pipeline stents, and about 90% occlusion rate of aneurysm. As you see in this picture, this giant aneurysm with white neck, and use of flow diversion in ITA segment, and after follow-up.
Nurimanov Chingiz, sorry for disturbing you, but demonstration of a don't see.
Oh,
we can't see the imagination of your presentation.
Они не видят демонстрацию.
Yes, thank you. Now we see.
Oh, okay. Everybody see my presentation?
Yes, yes.
Yes, now yes.
Ah, okay. I'm gonna start a history of aneurysm surgery. The first time to clip aneurysm was performed by Walter Drendy in 1932. As you see, this is a club by name is Walter Drendy, and he is our foundation. And Gazi Yashirgil in 1967, first time performed extracranial and intracranial bypass. He used STA superior temporal artery and MCA middle cerebral artery bypasses. After this, in 1990, Guido Guglielmi discovered us spatial coils. This is detachable coils which use it to embolize aneurysm. In 2011, and another special option in the world start use it. This is pipeline endovascular devices. What does mean? As you see on my presentation, you see a giant white neck intracranial aneurysm. Oh, this is right internal carotid artery. This is aneurysm. After this, we use special devices, pipeline endovascular devices. And as you see this picture, aneurysm is occluded after 3 months. And we use a next generation of pipeline devices. This is a pipeline shield. And the occlusion rate, these devices about 90%. The future of endovascular surgery. And more other devices we use in endovascular surgery. As you see, this is a barrel remodulating devices. As you see, this is aneurysm, and this is special stent to prevent migration of coils. And pulse rider, this is all newest articles and newest devices. As you see in this picture, this is pulse rider, and we use this for white neck aneurysm. And aneurysm has a Y or T shape. On this picture, this is a special microcatheter under these coils. This pulse rider to prevent migration coils into the vessel. And occlusion rate about 90%. And second option, the newest option, this is a P-conus and a P-canvas. The difference between P-conus and P-canvas has a special membrane on the apex, as you see in this picture. And embolization and occlusion rates is so high, like pipeline endovascular devices. And the new devices is Comaneci devices. This is mechanical stent which used to prevent migration risk coils. And the newest devices in 2019 is Silk Vista baby devices. As you see, this statistic analysis, very good and useful device. And I wanna talk about complex aneurysm. Everybody knows Robert Sperzel and Hanna. What did you mean this complex aneurysm? Complex aneurysm, all giant aneurysm into a group of complex aneurysm. And the second characteristic of complex aneurysm is location or difficult morbid access. What it means? If aneurysm is located posterior circulation, basilar trunks, it's complex aneurysm. Configuration, all white neck aneurysm is complex aneurysm. Branches arising from aneurysm, and calcification, intraluminal thrombosis, absence of collateral circulation, and previous treatments, it's all categories into a complex aneurysm. As you see, this statistic, mortality rates of untreated giant aneurysm is very high, and about 65 and 100% after 2-5 years follow-up. And rupture rate about 10% per year. And what we should do if we see a giant aneurysm, we should treat, and we need to choose more safe and efficiency options. And in our center, in my center, we use special options. All patients, we did a gold standard method is cerebral angiography with 3D reconstruction. We want to determine the size, shape, configuration of aneurysm, and all patients assessed by MRI. We want to know natural size of aneurysm. And treatment strategies of giant intracranial aneurysm. As you see, as DCA, digital subtraction angiography. If aneurysm has a narrow neck, no stenosis, kinking of ICA, and a negative of balloon occlusion test, we use a flow diverter deployment. After, if we can use a flow diverter deployment, we occluded a parent artery. We occluded internal carotid artery. If his balloon occlusion test is negative, this is more cases we use an extracranial intracranial bypass after this anterior ligation of or embolization or occlusion by angiography by coils. I want to show you illustrative cases. As you see, this angiography and MRI, this is a giant intracranial aneurysm. We use the pipeline endovascular devices. After this, a follow-up after 4 years, you see aneurysm is disappear on control angiography. All parent artery is good and no aneurysm. This is the first option. And the second option, as you see this picture, patient absent iodine, A1 segment of anterior carotid artery, and patient has a negative balloon occlusion test. We should use a bypass, extracranial, intercranial aneurysm, and we obliterated in ICA. As you see, is follow-up, aneurysm is disappear, and internal carotid artery disappear. All left side of brain supplied by ST anastomosis, superficial temporal artery. And the third cases, I wanted to show you another giant aneurysm. Patient has a ACOM, but balloon occlusion test was a negative, but as you know, about 50% of balloon occlusion test has a false negative result. And after we use a pipeline endovascular, after we ligated internal carotid artery, patient has aphasia, hemiparesis, and we emergency do it bypass surgery. This is a control. Our bypass supplied left side of brain. And another cases, as you see this picture, we have fusiform multimodal aneurysm of M1 segment of MCA. And what we should do in these cases, we decided to use a double bypass technique and use a pipeline endovascular devices because about 30% of Asian people has a resistance for clopidogrel, and this patient has a resistance for clopidogrel, and we should use a protective bypass. This is a double bypass technique. This is sutured 10-0 nylon. And in this picture, we check bypass patency and the balloon occlusion test. As you see, all two bypass work, and we use the pipeline endovascular devices. And all two bypasses worked. After this, 3 months follow-up, angio control, aneurysm is disappear, our bypasses is work, and ICA is work. And the conclusion, no matter how you good in endovascular surgery, you should use neurosurgery, microsurgery, because if you have a bypass technique, this is your safe parachute. And in all cases, in stent thrombosis or emergency cases, you should use a bypass, and it saves your patient. Okay, thanks for attention.
Thank you very much, Chingiz Sagadatovich. If somebody have a question, please you.
Thank you. This is conclusion in our center. Sorry, I don't hear you.
Ермек, тебя плохо слышно.
Извините, я вас не слышу.
Can you hear me now?
I'm sorry, I don't hear you. Thanks, everybody. If you have no question, I'm good. Thank you. Goodbye. Nice. Goodbye, everybody. I hope we see you
Thank
next
you.
time. Goodbye.
Thank you for
Thank you very much for
Thank
such
you.
a good session.
Thank you very much.
Have a good one. Bye.
That was very interesting.
Goodbye.